of interest. So let's move on. Speaking of which, you show me the incentive, I will show you the outcome. That's according to Charlie Munger. Well, let's go ahead then and take a quick peek about, look at the NIH panel that's going to be setting the treatment guidelines. 50 doctors sitting on that. Out of those, we find 9 of them with, I don't know, some sort of incentive structure here that we might notice, possibly. Comes from this link right here. So they have to provide these disclosures. And of course, we see them having various conflicts. Potentially, they're having research support, so they get money to perform research. They're consultants. They get honoraria. They're on the advisory board. They have stock options too, things like that. So yes, these people have very tight relationships with Gilead, and they're going to be talking about Remdesivir. And I think Remdesivir has gotten a pretty free and easy pass compared to, I believe truly that if there was data like this, that if these people had all been prophylactically on Remdesivir, $1,000 a dose, that you'd be reading all about these studies. They'd be pushing them right there at the NIAID, and you'd be hearing about it on the media and all that. But hydroxychloroquine's really not a sexy drug. It's $1 a pill. Nah, not even 10 cents a pill, probably at scale. So it's not quite as exciting as a brand new drug at $1,000 a dose. But just to show you how other things can be treated, even though it's anecdotal. Remember, that's a big thing. You talk about hydroxychloroquine. Oh, it's anecdotal. It's just all anecdotal. We don't have any good science. Very dismissive articles in both tone and substance. Well, let's look at how the tone of this article. Anecdotal evidence is now overwhelmingly positive. Nearly 2,600 COVID-19 patients with the U.S. have been treated with plasma. So I like the plasma therapy. Remember, you pull out the blood from somebody who's been infected, and you take away the red blood cells, and you're left with the plasma, which has circulating antibodies in it. This came from yesterday, the 29th of April. So just look at the tone here. All of the patients have tolerated the plasma transfusion, said Abney Dand, director of the Antimicrobial Stewardship and Transplant Infectious Disease for Westchester Medical Center Health Network. Geez, that's a mouthful. We are in the process of analyzing the data to try and tease out the impact of plasma transfusion and the outcomes of these patients. Okay, very good. And 5 of the 14 patients at UW Health suffering shortness of breath were treated before reaching intensive care unit and wound up never requiring transfer to the ICU. There seems to be a sweet spot where patients are early in that disease process. Hey, that's right. The earlier you can catch this disease process, the better, of course. So, and I'm a big fan of this. If this works, I'm a fan of this too. We've not seen any huge safety signals. The anecdotal evidence is overwhelmingly positive, says Michael Joyner, anesthesiologist at Mayo Clinic. Hey, remember Mayo Clinic is the same place that told you that it would be irresponsible to advise people to use hydroxychloroquine given the great risk of it, which we couldn't find the risk in any of the data that we looked at. But at any rate, there's Mayo Clinic talking about the overwhelmingly positive aspects of plasma therapy, right? As doctors, we're hopeful. As scientists, we have to be objective. Congratulations. I agree with that totally. We're quite encouraged by the results we've seen. Nationally, what we're hearing is that it does appear to be quite a safe treatment. So again, these are all very positive statements, and just the way it's framed and almost like a free pass, really, if you will, compared to, I think, the derision and skepticism that's treated hydroxychloroquine. They're just not on the same thing. And I'm not sure who set that tone and decided that, there was going to be a bias against this and for that and all that other stuff. But you have to remember this, and you have to remember this. The incentives drive everything in this story. What incentive is there really for a lot of the people out there to really be talking about something like hydroxychloroquine, right? So, here with plasma, it's an interesting thing. For plasma, you got to take it out. You're probably just going to give nothing to the donors, right? That nothing, maybe a lollipop at the end, but they get a Band-Aid at the crook of their elbow. That's what they get. But then, there's thousands and thousands and thousands of dollars that get generated from that plasma along the way. It's extracted and delivered, right? So again, just thinking through the incentives of all of this, if hydroxychloroquine can actually provide this protective effect, so you don't even have to go down the treatment pathways, then you just got to remember what the incentives are in this whole story. And I hate to frame it that way, but that's how life works. All right. Remember, we keep talking about the flu and the flu this, and, everybody's trying to say, well, flu creates an IFR of this, a CFR of that, on this basis, that basis. COVID is, just as bad or no worse than the flu. But it's important. We pointed this out a couple months ago, and I'm just going to drag it up again because there was a new article out by Jeremy Faust here that I thought did a great job pulling this out. Comparing COVID-19 to flu deaths is like comparing apples to oranges. The former, COVID-19 deaths, are actual numbers. The latter, flu deaths, inflated statistical estimates. So let's read into this article. In late February, when the stock market was beginning to fall over coronavirus fears, President Donald Trump held a briefing at the White House to reassure people there was little chance of the virus causing significant disruption in the United States. I want you to understand something that shocked me when I saw it. He said, the flu in our country kills from 25,000 people to 69,000 people a year. That was shocking to me. His point was to suggest that coronavirus was no worse than the flu, whose toll of deaths most of us apparently barely noticed. But these arguments, like the president's comments, are based on a flawed understanding of how flu deaths are counted, which may leave us with a distorted view of how coronavirus compares with it. When reports about the novel coronavirus 2 began circulating earlier this year, and questions were being raised about how the illness it causes, COVID-19, compared to the flu, it occurred to me that in 4 years of emergency medicine residency and over 3.5 years as an attending physician, I had almost never seen anybody die of the flu. I could only remember one tragic pediatric case. Based on the CDC numbers, though, I should have seen many, many more. In 2018, over 46,000 Americans died from opioid overdoses. Over 36,500 died in traffic accidents. Nearly 40,000 died from gun violence. I see those deaths all the time. Was I alone in noticing this discrepancy? So notice, if 69,000 people were actually dying from the flu, somebody who notices these things that number in the 30s and 40s thousands would have definitely seen a lot of flu deaths. But so we noticed this discrepancy. Carrying on, this sort of explains it. The 25,000 to 69,000 numbers that Trump cited do not represent counted flu deaths per year. They are estimates that the CDC produces by multiplying the number of flu death counts reported by various coefficients produced through complicated algorithms. So, and they're never squared up to reality, by the way. These coefficients are based on assumptions of how many cases, hospitalizations, and deaths they believe went unreported. In the last 6 flu seasons, the CDC's reported number of actual confirmed flu deaths, that is, counting flu deaths the way we are currently counting deaths from the coronavirus, has ranged from 3,400 to 15,600, which is far lower than the numbers commonly repeated by public officials and even public health experts. Yeah, 3,000 to 15,000 is way different from 25,000 to 69,000. Totally different. So conclusion 1, flu deaths is not a real number. Conclusion 2, trusting CDC flu models, which many people are doing to compare COVID and downplay it a little bit, but then not COVID models, it's kind of flaky. You got to pick one way or the other. Are we going to trust CDC models in this case, but not in this case? We're going to handpick. We love models. We hate models. Dad, just go with one. But I actually like things to be counted. And again, we're going to go with the excess mortalities in this story because there at least you can see what the overall mortality rate is in a given population. And against that, we don't see those typical, like where are the giant flu death bumps, right? We don't see them in New York City. So in particular, this was another take on this same storyline here. COVID-19 no worse than the flu? Hardly. In New York City, they found raw CDC data indicated 619 flu deaths from February 1st to April 18th, as opposed to the agency's count of 5,870 COVID-19 deaths in the city. So 9 times worse there by that. All right. So the conclusion from that is, flu isn't even the flu. It's probably way overstated because it's a modeled number, and just using the hard numbers that we have, it looks like roughly, roughly around a 10 times higher mortality from